Thanks, Dick. Now, that's a hard act to follow, but I'll get on with it. So I do own stock. My father-in-law worked for a pharmaceutical company, and we inherited all his stock. So I don't know if it has any conflicts with stuff that I'm going to talk about, but it's certainly possible. And I'll let you look at the objectives, because I know most of you in the audience are clinicians, and this stuff that I'm going to talk about might be really familiar to you and stuff that you have kept up with. And if that's the case, I won't mind if you go sit out in the sun for the next half hour, but make sure to come back for the next talk. But I'm hoping that I'm going to give you at least a few of my takeaways after having delved into this topic in more detail, preparing for this talk. So you already heard from Dick about the global problem. And in the U.S., even though the prevalence throughout the world has declined, the prevalence in the U.S. appears to be staying pretty stable. And there's a lifetime reactivation risk of 5 to 10%. So it's estimated that of the people who are infected right now, we're going to have about 500,000 to 1 million who go on to develop active TB if we don't do something different than what we're currently doing. So you already saw people who should be screened, and this is familiar to you from your ID fellowship, from your residency, from medical school. And if you recall that the reactivation risk is greatest the sooner you are from having had that contact. So although we probably should be screening, as Dr. Brostam said, all immigrants, people who have recently had contact, those are the people who are at the most risk of reactivating and getting active disease. Now, I'm not a pediatrician, so as I was preparing for this talk, it was a good reminder to me that how vulnerable kids are. And that's why people who treat children use window prophylaxis for kids under 5. So if you have a child who's young and they have you're screening them, even if their screen is negative, but they've had a recent contact, they get started on prophylaxis for TB. And then you may re-screen them again in 12 weeks, but you start that prophylaxis so that they don't reactivate and get active TB while you're waiting to make a diagnosis. A lot of our information about reactivation and latent TB comes from old studies, but there are new studies being done, and a recent Danish study showed that pretty much what we've thought in the past, that overall about 2.5% risk of developing active TB if you don't get